I'm Doug Llewelyn for CUTV News in New York. On this edition of CUTV News Presents, we focus on a remarkable oncologist who is making what has to be considered amazing progress in the treatment of cancer patients here at the Hope Health Center in the Los Angeles suburb of Calabasas, California. And he is doing it by utilizing a new form of treatment known as precision oncology, which is based on an individual's genetic marking. And while it doesn't work for every cancer case, for those that it does, the results have been nothing less than miraculous. In fact, this treatment is considered so promising, cancer patients have been coming here from all over the country, as well as around the world.
As you know, genetically we are different. If we get cancer, the same cancer with same staging, our cancers genetically are different, so they should not be treated the same way. We have to get a personalized, customized therapy specifically designed for our genes, precision oncology or customized therapy. It's basically matching a medication or a drug to a patient gene. So all those treatment plan and customized therapy are unique and is specific for each patient, which means every patient will be tested for specific genetic marker causing the cancer to grow, and every patient gets a customized, personalized therapy based on those genetic makeup. So Hope Health Center is a center that try to find a protocol based on genetic test on the tumor and tissue, and we don't limit ourselves to the treatment, to a standard treatment. We may cherry pick any medication, FDA approved for any cancer, and put it together and give to the patient to improve their survival and quality of life. And we have seen success story. We have seen something that you can call it miracles.
I was diagnosed for ovarian cancer on beginning of 2016. In 2.5 years I was on treatment, chemotherapy treatment non-stop. And finally last July, 11 months ago, I was told, this is it, they cannot do anything else for me, and I have 6 to 9 months to live. So I came here and met Dr. Javadi, and he started treatment, and I'm here now. And day by day, I'm getting better. I should be gone, but still I'm here. I'm doing good, and cannot be better than that. I cannot believe it because it's like a miracle to me. I was ready to go. I gave up. But Dr. Javadi was helping me to back to life and enjoy with my family.
Patients are coming from different parts of the world, and they have different cancers. Many of them, they're coming here for second, third, fourth, even fifth opinion. They already failed standard treatment. They already failed clinical trial, or they're running out of option. And they are told, many of them, that there is nothing else can be done for them. And many of them, they are sent to hospice or end-of-life care. Those are the patients we see mostly in our clinic. They lost their hope. They're coming for the last resort, or basically some additional hope. And we try to find the best way and something to give their life back to them with quality of life. My first goal is improving the quality of life. If the patient is in pain, if patient has lost weight, if patient is very weak or ill, we try to improve that first. After that, we try to improve their longevity and survival. So if the patient gets better, the quality of life improves, automatically they are more motivated and encouraged to continue the treatment. They stick to the program, and they get better, and the survival get better. So all this connected to each other. Quality of life and survival. We don't want to prolong and extend suffering just for the sake of it and just to give the treatment for a terminal patient.
In general, is this kind of treatment considered to be unique?
The way we design these protocols and putting this together and give to the patient is not being done anywhere else because it's considered investigational, and patients are aware of that. When they're coming here, if they fail standard, if they fail clinical trial and there's no other options, they're lost. They don't know what to do. And if I tell them, I found some new genes and I can target that with some different medications, off-label medications, they accept that. They take that risk. And later on, future trial will show what we did was true. It gives us some credit for what we did in the past. Any patient sitting in front of me has no option, is going to hospice. If that patient is asking me, is there any other option, I don't feel comfortable if I say no. But if I know I can do something that might help and that's available to that patient, I just offer that to the patient and they accept it. And that's the difference between us and major center, because major academic center, they are not doing off-label therapy, which is something I think should be offered to any patient. We shouldn't separate these cancers from each other because mutations, genes, abnormal genes are shared between different cancers. If FDA approve one medication for certain cancer, but the other cancer has the same mutation, we should be able to use that off-label medication. That's what we do here, which is not being done in academic centers.
You use the term off-label quite frequently. What really is off-label treatment? What is that?
Let's say drug A is approved for colon cancer only, but drug A can affect a breast cancer patient also. So drug A is indicated for colon cancer by FDA approval, but if we use it for breast cancer, which FDA has not approved it for, it's called off-label. So many cancers that we treat, they have some genes that is in common with other cancers. And FDA generally so far has been approving medication based on each cancer, specific cancer type. So to be uniform and to be standard. So everybody can follow that. But we know for the fact these mutations are common between cancer. If we use one medication that is working for that mutation, if some other cancer has the same mutation, we should be able to use it, and that's called off-label use. Many oncologists around the country and world, they're using off-label medication on a daily basis. It's not uncommon. But I think for the cancer, we need to be more aggressive. If we use different medication at the same time in combination, we get even better results. And the clinical trial, recent trials have shown, all of them have shown, combination of different medication with different mechanism of action work better compared to a single modality treatment. And that's the fact. And that's what we try to do, to give a best combination to a certain cancer.
About 5 years ago, I was diagnosed with colorectal cancer. And lucky for me, it wasn't a very high stage. It was between stage 0 and stage 1, so it was caught pretty early. I had a regimen of chemotherapy and radiation at the time. And I was being cared by a different oncologist, as well as a colorectal surgeon and a radiation oncologist. They told me my cancer was 95% curable. I followed all the regimens, what they told me to do, and at the end of the treatment, the colorectal surgeon told me that I was cured. A few years later, sure enough, there was a tumor, pretty good sized one, in the same area. So the cancer actually had come back. That was a major turning point in my life because I was so sure that I was going to be the 95% that would be cured. But there's got to be 5% that isn't, and I was one of them. I didn't know where to turn. I didn't know what to do. My colorectal surgeon brought me and my husband and my mother into his office and basically said, the only way we can get rid of this is you're going to have a major surgery and you'll have to wear a colostomy bag for the rest of your life. I refused. Not because I'm vain, I just felt that there was something else that could be done. So obviously I started researching my options. I don't even remember how I got to Dr. Javadi. I think it was through my insurance that they had told me, go and see this doctor. And I was totally against it. I actually wanted to go to the big guys, UCLA. I wanted to go to cancer specialty. But I did come with the hopes that this doctor Dr. Javadi would actually send me and say, no, this isn't something I can do. I'll send you to even more of a specialist. Well, lo and behold, I came. He totally researched my situation. No guarantees, but he said, I'm going to try something out of the box. And it's up to you. Do you want to try it or not? Of course, I was ready, willing, and able. I did not want the knife. I didn't want to be disformed for the rest of my life. And I went through the chemotherapy. He put me on an immunotherapy. I changed my diet. The staff here was very uplifting, very accommodating, because when I first got here and started the treatment, I was hysterical. I could not keep, when I think about it, I even want to cry. I couldn't keep a straight face. I was so scared. Because I said, if this doesn't work, I'm going to have to go under the knife. I won't have another option. Because there really wasn't any other. And I kept praying to God that this is going to work. And luckily, with the experience and the know-how and the thinking out of the box, Dr. Javadi and his staff, I did a PET scan last June and my tumor is gone, where nobody thought that it would be gone. I'm very grateful, very, very grateful. I'm in recession since last June.
You know, a lot of patients come here and it's their last resort. They've given up hope. Are there any patients you ever don't accept?
I always say to patients, if anybody can walk, talk, and eat, and they come into my clinic here, they have still a chance for a treatment, a chance for survival. So if they are in bed, if they are in bed all day, if they're not eating, if they're not conscious, I think those patients may get more harm than any benefit by the treatment. So these are my rule of thumb criteria to treat any patient, advanced cancer.
How does the medical community in general respond to the kind of treatment you're doing here? What do you hear?
There are two different approaches to our clinic by other doctors or academics. Some academic centers, some doctors that my colleagues working in community or academic center, they approve us, they praise us for what we do, and sometimes they even refer patients to us because they don't have anything to offer to their patients. And we also have negative reaction feedback because they think that what we do is out of the box and not standard. But I can challenge that concern because when the patient has no option, when the patient is not a candidate for trial, when the patient has failed standard treatment, and patient and the family member would like to have additional option, then what you're gonna do? You just sit and watch them, or you want to do something for that patient? And those are the patients that come to us, and they get good results. I would say 80% and above, they get good results. I'm not claiming we cure stage 4 cancer. There is no cure. But if you improve the quality of life, if you give them some additional chance to live a little bit longer with good quality of life, why not? They take that option, and they take it seriously. And that's how we work with this patient, and we try to help.
We started in March 2018, and I was in a lot of pain. When he started the treatment, a month later, my pain went from 100% to probably almost nothing. There was no pain left. The chemotherapy and the combination with the immuno was working wonders in my pain. So then the tumors were reducing and then disappeared in a matter of 3 months. It is amazing the way I felt in the very, very beginning. I was taking painkillers every 4 hours. And I came to my first treatment and I was just crying because I was in so much pain. And Dr. Javadi said, well, my goal for me is to reduce that pain right now. So we had the first treatment, and it was just, after the first treatment, it was just like a miracle, because my pain went down like to 0. It was just amazing. I couldn't believe it. It was just amazing.
If you can do something good for a patient or someone, and you think you can do it, I think we should do it, and we should forget the bounds and regulations and all those things, because this is a real life. This is helping the patient. This procedure, precision oncology, works on many patients. And I think not long from today, I believe maybe in 5 years or so, it's going to be a standard. It should be a standard. Any patient with a specific gene, if it's there in trial or approved by FDA, should be available to that patient. We shouldn't avoid that. That's very important.
Dr. Javadi, do you think this treatment that you're doing here will become the norm in time?
Definitely. It can happen. And actually, the thought leaders now, any of them, you talk to academic center, the future of oncology will be precision oncology, customized therapy. Each patient is unique, and then any medication approved by FDA should be available to those patients. The problem is, who's going to pay for all this cost? It's costly. We accept that. But if you give a right treatment, you can control even the cost, future cost, by putting the patient in remission sooner. So I think it would be cost effective if you think it that way.
I understand your practice is actually expanding to other countries as well.
We are part of a joint venture with a big investment company, a medical investment company from China. And we are working, collaborating with many hospitals in mainland China as well as in Hong Kong. They are investing in precision oncology, and they would like to expand this kind of approach and treatment to their patients in China. We are trying to establish precision oncology department in those hospitals for collaboration and working with the Chinese doctors. We have visiting doctors from China here, coming here for training and shadow me and see what we do here. We are also working remotely with their doctors through the webinars. I do consults online with patients and the doctors in China. We've been able to help many of those patients by remote consulting and give them recommendations and treatment protocols. But unfortunately, the problem with China and other countries, many of the medication we are able to use here in America, either off-label or as indicated, are not available in those countries. And to the point they have to come and travel over here, stay here for a few months or sometimes a year to get the treatment they need, and then they go back to their home country and continue as maintenance therapy.
Explain the TV setup you have here in your office for consulting with doctors literally around the world.
When we get the request for consult from foreign countries like China, or we have patients from Middle East, from Europe, I've been doing consult. With Canada, we do a lot of consults. They call our office and they send their reports, all the documents by email. When they send it over here, I review them, and then I suggest some procedures, some tests, additional tests. We ask them also to send their tissue from their country, if they have tissue block from the biopsy here, for us to have them test genetically here in America. After putting all this together with reviewing their imaging studies, I pick up the phone, or we set up an appointment for them by phone, or even through the Skype or some websites we can do it. Those are the confidential websites basically. And then we do the consult either with the patient or with the treating physician, sometimes with both of them. And then we evaluate the patient situation. I can see them through the camera. I talk to them and talk to the treating physician. And then we come up with a plan, with the treatment protocols. If they are able to provide that protocol in their home country, they do that. If not, we suggest them to come over here to be treated temporarily, and then after they become stable and cancer is under control, then they can go back to the home country and continue the treatment over there.
Dr. Javadi, when you come right down to it, do you think cancer will ever be conquered?
Good question. Cancer, I would say right now in the horizon, I don't see any concrete cure for a cancer like pancreatic cancer, stage 4. But it's feasible to say that we might be able to make a deadly cancer stage 4 to a chronic disease, which has been already started. So in the past, if you look at the whole data from 1970s till now, we have seen a shift in survival, upward shift. The survival has increased by average 5 to 10 years for all stage 4 cancers. The reason is, one, the treatment are better treatment, immunotherapy, other chemotherapies, and the surgery and also the diagnosis have improved significantly. All those things, when you put it into perspective, we come into one conclusion. Cancer can be controlled, although may not be cured. Stage 4 cancer, not early cancer. Stage 1, 2, 3, many of them are curable. But stage 4, they can live longer with good quality of life. We can turn it into a chronic disease. Cure, it's something probably remote at this time. But you will see multimodality treatment for specific cancer. You see more customized therapy for the cancer in the next decade or two. But there is no magic bullet yet. And I don't think in our lifetime that's going to happen. Cancer is very smart. That's the fact. Smarter than our body. Can adapt to new environment, to new medications in as soon as a month. There's no other living tissue other than cancer can adapt to their environment that fast. So dealing with a beast like cancer, stage 4, which can change and evolve and change mutation, any angle you target the cancer, they can respond a month later. They shut down that pathway and they can use another pathway and continue to grow. Dealing with that cancer with just one medication, 2 medication, won't be successful. But whether we can control it, we can make it livable, we can make it like a unwanted, guest in our body. Yes, we already started, and I think we're going to do better in the future, even if we don't cure.
And there you are, a look at what many consider to be the future of cancer treatment protocols being utilized today by Dr. Javadi here at the Hope Health Center. I'm Doug Llewelyn reporting for CUTV News from Calabasas, California.